And we've got a stellar lineup for you now of international experts who've been involved in strategic disaster planning. And it's a time now to reflect on their expertise in this area, and particularly, obviously, in the light of unprecedented pandemic with the COVID-19. We're going to introduce each of the 5 people on the panel who have yet to speak. We've actually got more than 5 people on our panel, but the 5 who've yet to speak are going to give us just a 2 or 3 minute, one slide overview of their reflections on disaster planning in light of the COVID pandemic. And the first of those is Fred Hosea. So I'll hand over straight away to you, Fred.
Okay. Thank you very much. First of all, I want to compliment the presenters on a masterful range of reporting, analysis, and creativity in addressing a terribly complex situation. Yadin David and I have been beating the CED drum for disaster preparedness for many years now, and now may finally be the time when we can take on the challenges as an organized global team. CED has evolved amazingly since our early beginnings as a small Yahoo group, so I add deep congratulations to our history of board members and chairs who have gotten us to this point. The COVID pandemic has made it unarguably clear that disaster preparation and management need just as much professional attention as do daily operations. I want to suggest here that we need to pay equal attention to the design engineering skills that are needed to fulfill both patient-centric needs on a daily basis as well as global alignment needs that appear during disasters, and not just think of clinical engineering in traditional terms of operational HTM and HTA. Our daily operations can provide critical feedback into the design of next generation of devices and processes that we'll be supporting for the next 5 to 20 years in both normal and disaster conditions. Healthcare engineering needs to combine HTA, design, and HTM, and should not be limited to devices, but also include process engineering that includes severe contingency management as a key component. We need to add HTD, health technology design, to our professional vocabulary and skill sets. Feedback from the operational field of controls is critical to designing the next generation of improved devices and processes. This makes it even more important to have high quality integrated asset management and service management tools to track device performance, to measure the types of failures that occur, and learn from that about how to design the next generation of devices and processes. The past year of COVID management has given us a huge amount of data to work with to improve our systems and expand our professional skill sets. In the complicated design diagram you see here, we see how the 3 axes of clinical engineering skill sets, designing, scaling, and controlling, define the global shared space for clinical and biomedical engineering innovations. These key skill sets are needed to organize quality healthcare that spans from the micro scales of medical physics and molecular therapies all the way up to global collaborations on standards, policy, collaboration, and funding of equitable vaccination strategies such as the COVAX Alliance. Not everything can or should be solved at the local level, so the more you work with academic, government, and industry partners, the better. The panel on the left lists some high-level suggestions to strengthen our ability to prepare for and manage future disaster situations. So you can read them later and try and figure out the diagram when the materials, the webinar materials, are distributed to you later on. I would like to add 2 things to the list. One is we need to create a global health innovation registry to enable more coordinated real-time tracking of medical innovations in both normal and disaster circumstances. And I think we need to establish a permanent CED working group on disaster management to get us all working on this in a sustained manner. At the bottom left, there's an article that I wrote that was published in the Global Clinical Engineering Journal, Emerging Horizons, that goes into much more detail as well as comprehension about the challenges we face. But I hope that with that article and with this diagram to provide a space that will help us work coherently as we pool our talents to create basically what I call a dual use infrastructure, where everything is designed to work equally well under disaster as well as normal circumstances. So thank you for your patience in this hurried presentation.
Brett, that was brilliant. You seem to have managed to get multiple years of experience in one slide and 3 minutes, so that was perfect. Our next panelist who's going to give us a 2 or 3 minute overview needs no introduction, so I won't bother, but it's Yadin David.
Thank you, Dan. I'm delighted to join this esteemed faculty panel and dynamically two moderators, Dan and Shauna. What I would like to do is to raise the questions where we in the health technology management adequately prepared for this disaster. I'll put a mirror in front of us, including myself, and try to answer that. It is one of the many lessons that we learn that science and technology is the base of living on this planet, and science discovery and engineering problem solving working together is a perfect lessons we learn from this COVID-19 disaster. But it requires improvement. What we are seeing is not sufficiently adequate for meeting our expectations. In March 2020, the Journal of New England, the New England Journal of Medicine, excuse me, the New England Journal of Medicine published an article that specifically said what is happening and why do we have a critical shortage of life-saving technology, such as specifically they address ventilators and personal protective equipment. In addition, when we pulled out ventilator from national stockpile, some of them did not function and were not inpatient ready. So it's obvious that we not only have shortage, not only, as Ray correctly says, not having enough information where things are, but also we're not prepared. And we need to be better prepared, especially in the clinical engineering profession. We need to take our action plan from the local hospital, as Dan described, that a few hospitals in the UK are getting together as initial response was the initiation there, not a national plan. We need to take the local, put it together with the city, with the national, with the region, and with global policies and plans, so we are better prepared. We don't need to be in a position that car manufacturers and medical device facilities are getting together in order to bring ventilators to save lives. We need to be better prepared to that, to realize that competent personnel, equipment processing, standards, guidelines, policy, and regulation should be in place so we can do better through global networking, have better knowledge, and therefore decision-making processes with competent personnel. The world is dependent on the availability of patient-ready healthcare technology as well as facilities and point of cares. We therefore must rethink technology management beyond what we do so well in our own institution. The new organization, Global Clinical Engineering Alliance, is developed exactly that idea of bringing parties together, making alliances to collaborate in order to find the proper action plan, in order to find best practices model and spread it and make sure that we are having the tools to educate, advocate, and empower the clinical engineering profession to be better prepared, having the resources and position ourselves to more optimally be bringing a better and safer future for patient care everywhere in the world. I would like for you to keep attuned to the Global Clinical Engineering Alliance that works so closely with CED on the programs we bring together, and hopefully we'll find partners like Ray, like Lee, like Roberto, like Tanzin, in every place in the world where we can do that better next time around. Thank you very much.
Yadin, thank you. As ever, your wisdom and concise words, I'm sure, will stimulate debate and thought around the globe. So our next panelist, who's going to try and distill all they know about disaster planning and COVID, is Toby Carl. Toby.
Just want to thank Shauna and Dan, Tazeen, Roberto, Ben, and also Ray for just outstanding communication on the work that you're doing. It's so important at this time. In particular, COVID-19 is a area where we need to react quickly, and to do that speed is important. We have to know what we're dealing with, what equipment, what parts, what documentation, what staff are available to be able to deal with the emergencies that come up. So I just had a couple of key messages, and I'll be short. I think that we've seen that standardized nomenclature and accurate physical inventory, unfortunately, that is what is required to get the right data into the system, and strong collaboration and stakeholders. So Tazeen and Roberto had talked about the collaboration that they have with institutions in their countries to be able to put together the systems that they have for asset management, which is just outstanding. In terms of the discussion under the heading parts and manuals, and I think that went well beyond that particular heading. You know, I think probably nobody in the world knows this area more than Lee Bing and Ray Dalton. Certainly PartSource has been such a great company that has expanded greatly in the US. That was started by Ray. But we need to know, not just, we got to go beyond just, we have to keep X starts parts in stock. We have to really know what's available to us locally, what's available in a timely fashion, what will work, what won't work, and know this on a national, regional, and international basis. And what are those alternatives for finding those parts? So in dealing with a national system, you know, a centralized source of service, as Ray described, for Haiti, in particular northern Haiti, and as Li Bing described for the Shanghai area in China, is really essential. To go beyond that in terms of documentation, that's really what is required to be able to service all systems. Ray talked about something like 28,000 different manufacturers and models just in Haiti. That really is a challenge to be able to have that available. On the other hand, let's go beyond that and look at, you know, what video training may be available to actually perform that service. It isn't always descriptive in a printed manual or a PDF. So, you know, that's something to think about in the future related to service and training and basically getting the support that those devices need, particularly at critical times related to COVID. So again, thanks. It's great to be part of this event, and appreciate Tom and others for inviting me. Thank you.
Toby, thank you very much for that brief overview. I'm so pleased there are so many people on the line and watching this live at the moment, because we really are being privileged to hear some of the great minds of our profession giving us their view on such an important matter. And that continues now as our next panelist, Jean Kuhn, or Alan, as he's known to most of us, is going to also give us just a quick overview of his perspective. Alan.
Okay, thank you, Dan. From the role I play as a director of Logistics Service Department, includes clinical engineering, facility engineering, catering service in Children's Hospital of Zhejiang University, And as Secretary General of Chinese Society of Clinical Engineering, CSE, one of the impressive lessons I learned from the pandemic is in addition to skill set, clinical engineers and technicians need mindset training. Scientific research shows that people's minds might be built more to look for negative information and to hold on to it, in particular when a pandemic like COVID-19 occurs. Panic, angry, confused, low-spirited. But we can also retrain our minds if we put some effort into it by looking positively. As a picture in the left bottom of the slide shows, this is a self-train and evaluation tool and helps get people motivated. It is important that in face of crisis or calamity, we need to adjust our minds quickly with open and growth mindset. Before and after pandemic outbreak, I think the clinical engineering working mode is shifting obviously towards teamwork with broad circle of team players. Some might be uncommon before, such as facility engineering and housekeeping staff. Things combating COVID-19 needs all on-site services and persons collaboration. And some exciting prospects of new technologies facilitating CE and HTM, such as clinical engineering platform based on ICT and Internet of Things, which are already with deployment in more and more hospitals in China, as shown the picture in center. The digital twin information mirroring model dashboard is not only intuitive and attractive, but also practical and useful with many features of integrated centralized monitor systems such as online environment of temperature, humidity, power supply, and equipment operation monitoring, equipment allocation and dispatching, etc. Another worthwhile mentioning interesting technology with potential wide application, as shown in the right side picture, touching without touch, new way of interacting with machines, touch-free in the air with a floating panel, brings a lot of benefits in terms of infection control and manpower saving for keeping the machine sanitary. Finally, I just want to mention that CSE, as Chinese Clinical Engineering Professional Association, its great role played as trustful information clearinghouse during the pandemic. CSE also helps to issue COVID-19 medical equipment infection control and management protocols, and published book titled Guidance for PPEs against COVID-19, as shown in the slide 2. Okay, thank you. Thank you all very much.
Alan, thank you very much. A wonderful overview of your ideas and thought. I was particularly taken with your very first point about the skill set, that changing our mindsets as clinical engineers is something that I think is going to be really important moving forward. I need to move us on. I'm aware of the time. So our final panelist to present, last but most definitely not least, is Rosanna Rivas.
Thank you, Dan. An amazing collection of insights and contributions. I just want to propose sort of discussion, mental insight to discussion. We have no time yet, but global disaster created by COVID-19 has trapped us globally in a number of deaths. Collapsed health services, of course, is worst in the low middle income settings, and the learnings are around health technology management, clinical engineering, skills developed in an unexpected level should be done rapidly, effectively, but also smartly. What I discovered, the best solutions, the best approaches come from the out-of-the-box perspective. And this is something very valuable in these last 2 years. Decision-making based in evidence, and that's why we are working globally very much on searching information, best cases, good references. Hacking Coronavirus-19 team, we work daily, is such a little example of how much we are aware about the value, pertinence, but high impact to have correct information, exact information on time to solve or to approach to understand better the problem. Some emerging projects, some emerging interventions that are going through this pandemic is also, in this case of the disaster context, is also these partnerships you made before, collaboration, teamwork, networking, unbelievable. The church, the academia, and the enterprises joined together to make something beyond, with, or in parallel to the government. We cannot wait for the government. We cannot wait just for the university or the nonprofit. We have just the obligation to be on time. Finally, clinical engineering role in COVID-19, in my opinion, have an outstanding mission around the support to health services. Not just improvement, maintenance, all the etc., but also to develop applied research. Work on applied research, collect information to make it better, publish. And that is a new challenge for us, because before the pandemic, we said we don't have time to publish. We don't have time to write. We have to make time to write. We have to make time to share information with others through articles and others. Finally, and I promise I will send to Kali Roy kindly 2 articles that we wrote, one with Yadin David and Toby Carl about education successes for disaster preparedness from the perspective of clinical engineering, analysis comparison between Ethiopia, Peru, and Philippines, and the other one, another article, this time done with Yadin. This was disaster preparedness and how clinical engineering's role is improved in the last times. And these 2, I believe, would be very useful for this discussion in the future. Thank you.
Rosanna, thank you very much indeed for that wonderful overview. Which brings us to the end of our 5 panelists who we've allowed to actually have a slide and speak